Right, so we've got another MLA condition series. So I've called this one Vascular Neurology. It encompasses stroke and TIA. It's quite a big one. So stroke is some people say the second, some people say the third most common cause of death in developed countries, but it also causes significant morbidity. So if you have a stroke, you can end up with quite profound disability, which has implications for yourself, for those who care for you, and the community at large. And stroke, you know, in sort of ancient literature, apoplexy, like struck down by the gods, very, very sudden. And that's the whole kind of, you should always remember that the hyperacute nature of stroke. It's damage to the brain due to disruption of blood supply to the structures. And there can be two real causes of that. One is infarction, so the blood supply is blocked, and that's often thrombotic, so due to a buildup of material in the intima of the blood vessel, sometimes embolic, so material from elsewhere going down the bloodstream causing a blockage, and 15% hemorrhagic, so due to a bleed into the brain disrupting blood supply in that way. And the risks are higher if you have high blood pressure, as you might expect, and what we call vascular risk factors, so diabetes, inflammatory conditions, cancer, you have a greater risk of stroke, smoking, atrial fibrillation. There is a rarer form of stroke which we see in younger people, particularly in women, but also malignancy as well, called a venous stroke or a venous infarct. We'll not really go into that here. So the pathology of ischemic stroke. So you'll all have heard of atherosclerotic plaques, and that forms in the intima, in the subintima of the blood vessel. So the intima prevents the leakage of blood into the vessel wall itself. And then when you get damage to this intima, which happens over time, you get bleeding into the plaque, or the plaque then sort of ulcerates or ruptures into the vessel, and that causes narrowing of the vessel or occlusion. These plaques can also cause emboli when material, sort of cholesterol type material, breaks off and goes downstream, causing blockages downstream. And a key point for that is the carotid bifurcation, and that can give rise to stroke. So cerebral infarction. So when we manage stroke in modern medicine, whenever we have an ischemic infarct, there's a core of tissue that you can't save, which happens very, very quickly, but there is a penumbra. So that's an area of brain which is under threat, but if you manage to resupply blood to that area of brain, it can be saved. And that's the aim of hyperacute stroke management. We call it reperfusion therapy. And there's a very time-limited scope to this. So I'm just going to talk a little bit about some of the ischemic stroke syndromes. So middle cerebral artery strokes are pretty much the most common, and they give you the classical stroke syndrome that everybody thinks of. So if you get a middle cerebral artery blockage on the right side, you will get contralateral hemiparesis, so left-sided weakness, numbness. If it's the left hemisphere, you can have loss of speech. We call it aphasia or dysphasia. If it's on the right, so non-dominant, you can get neglect or dressing apraxia, where you can't figure out how to put your clothes on your body. You can get hemianopia with visual field problems, and you tend to get the leg spared more than the arm. So anterior cerebral artery problems cause more leg problems, middle cerebral artery causes more arm and speech problems. The more distal, so the more downstream the issue, the less complete the clinical picture. So if you have a very proximal problem, then you get this sort of complete, very dense stroke with all of those features, such as the hemiparesis, the speech problems, and so forth. And you can get a very sort of partial or limited stroke syndrome if you have just a very small branch of a vessel downstream affected, such as just Wernicke's, giving you just receptive aphasia, for example. And you can also get very small, deep or perforating branches of the middle cerebral artery that give you very small infarct or lacunes, and that's where lacunar infarcts come from. And you get 5 main lacunar stroke syndromes. So you can get like a pure motor hemiplegia, so pure weakness down one side, get sensory motor but nothing else, hemiataxia, where you become uncoordinated on one side, pure sensory, and then another one called clumsy hand dysarthria, where you develop sort of apraxia and loss of dexterity in one hand, and you develop slurred speech. And how common a lacunar infarct is, how common that syndrome is downstream. So the pure motor hemiplegia is most common, and clumsy hand dysarthria is pretty rare. So a little diagram here of the cerebral vascular territories, which you'll see when you see the recording. And in red, you'll see the middle cerebral artery distribution, which is a significant proportion of the brain, and a lot of the business there of movement, speech, and coordination and praxis. So a middle cerebral artery infarct can give a very profound syndrome. And here we've got an MCA infarct shown on MRI. So when we do MRIs, we've talked about T1, where we see the sort of structure, T2, where we see inflammation or pathology, but also there's DWI and ADC, which is an MRI sequence that looks for ischemia. It looks for a disruption of blood flow. So here on the DWI sequence, we can see there's a right MCA reduction in blood flow causing a bright signal. So that's DWI change there. To confirm that this is ischemic and not inflammatory, you look at the ADC, which gives you a corresponding in the same territory reduction in signal. So you get dark areas in the same distribution. So it should be an inverse, a photonegative. If you get inflammation, that can look bright on DWI, but you often get a bright appearance as well on ADC. We call that shine through, and that allows you to discriminate. So some other ischemic stroke syndromes. So the posterior cerebral artery, it really depends on the branches affected, but we see quite complex pictures which affect the cranial nerves. So a midbrain syndrome, which can be called Weber's, you get a third cranial nerve palsy, so a down and out eye with a dilated pupil, and a contralateral hemiplegia. So you get the third nerve palsy on one side and the weakness on the other side, and that's Weber's. Thalamic syndrome, you can get chorea, so a hyperkinetic movement disorder or hemibolismus, a sort of flinging on one side, with a hemisensory syndrome. So you get this movement disorder on one side and you're numb. And you can get hononymous hemianopias, so visual field problems, and sometimes anomias, where you lose the ability to name objects. And then we've got the basilar artery. So with basilar artery, you get features of vertigo, ataxia, and also sensory motor problems. And quite often in A&E, there's often a discussion here, is this vertiginous patient, do they have a central problem like a stroke, or do they have a peripheral vestibular problem? A rule of thumb is if they have anything other than vertigo, so if they have numbness, if they have weakness, if they have eye movement problems, if they have speech problems, you cannot really put that down to a peripheral labyrinthitis. You need to look for a central problem. So a complete basilar infarct, you're looking at bilateral sensory motor problems, so a quadriparesis, cerebellar problems, multiple cranial nerve dysfunction, but they may also be unconscious or they may be in a coma. So even eliciting that may be very difficult. Top of the basilar syndrome, something that all neurologists fear. It can be a very heterogeneous picture, so very variable, but essentially people can be drowsy, they can just have altered, agitated behaviour, they get pupil changes, they get gaze palsies where their eyes may be turned to one side, or they might have ocular paresis where they're unable to move their eyes, and again they may be in a coma. Or you can even be locked in. So these are the paramedian perforating vessels. If you infarct in that area, you may have some horizontal movement of the eyes, but nothing else, which is a very scary phenomena. And you might have heard of something called the diving bell and the butterfly, which talked about that. And I've got a picture here of the posterior and cerebellar vascular territories. You can see that there's some overlap here, but essentially the basilar artery sort of supplies the midbrain and thalamus. And then you've got your anterior inferior cerebellar artery, which is more superior, and your posterior inferior cerebellar artery, which is naturally more inferior, which is what you'd expect because of the name. So I've got an MRI here of a pica and an ACA infarct. Quite interesting, also quite rare. We'll talk about vertebral artery. So a lot of people, they have a naturally hyperplastic vertebral artery, so one of their vertebral arteries is dominant. If you infarct your dominant vertebral artery, you're looking at a basilar occlusion because all of the blood supply goes through one of your vertebral arteries. So, you wouldn't have a dual supply. Lateral medullary syndrome, which is caused by obstruction of the pica, causes quite an interesting syndrome. So you get a cerebellar syndrome on the side of the infarct. You get a Horner's syndrome, so miosis and a slight ptosis. A hemifacial sensory syndrome, so you go numb and you have numb in the face and in the body. And you can get pharyngeal paralysis, so sudden onset hoarseness of the voice. And on the other side, on the contralateral side, you get numbness. So numbness in the face on one side with a Horner's, and you can get hoarse speech, and you're numb on the other side of the body, and you're very vertiginous, you're very dizzy. So if you have a sudden onset complex syndrome like that, you need to think about some kind of brainstem infarct. ICA, so it's a variant of a pica syndrome, but with that, as well as getting vertigo and ataxia and Horner's and facial numbness or weakness, you can also have hearing loss. So again, if you're in A&E and you have a patient who has lost their hearing and is dizzy, but they have other features such as numbness, weakness, ataxia, speech problems, then you cannot put that down to a peripheral problem. You need to be looking at a central brainstem syndrome like stroke. And cerebellar infarcts are often isolated, and you just get isolated ipsilateral ataxia. And there's a nice scan here of a superior cerebellar artery infarct. So when you're working somebody up for stroke, the obvious thing is you need to stabilise the patient if they're very unwell. Use your usual ABC. If there are signs and symptoms of stroke, you need to try and establish when the symptoms came on if we're looking at reperfusion therapies. If somebody is within the thrombolysis window, which is 4.5 hours, you need an immediate CT head, and you're doing that to exclude hemorrhage. You're not doing it to look for a stroke, you're doing it to exclude hemorrhage and see if they are a candidate for thrombolysis. Ideally, you would also want a CT angiogram because you can see a thrombus, and that can be helpful. Perfusion imaging, which is a bit more sophisticated, that shows the flow of blood to particular parts of the brain, and that can show us the penumbra. It can show us a part of the brain which is getting insufficient blood but is salvageable, and that can show us that somebody might be a good candidate for thrombolysis. That's really helpful in extensive stroke, because if everything is completely infarcted, there's no brain to save, and giving thrombolysis may well just cause a devastating bleed. And the MRI is often very helpful, as you would expect, with DWI and ADC, but it can be hard to get out of hours in the acute situation, but you can get it in some centres. So the reperfusion therapies, we mentioned thrombolysis, so tenecteplase tends to be what we use now, within 4.5 hours of onset. Absolute exclusions for thrombolysis, hemorrhagic stroke, that's the main one. If somebody's actively bleeding from somewhere else, if somebody is extremely hypertensive and you can't get the blood pressure down, you don't really want to give them thrombolysis because they're probably just going to bleed. If they have an arteriovenous malformation or other blood vessel abnormality they're just going to bleed from, or a brain tumour, which is suspected which would bleed as well. And caution, but you might be able to go ahead with thrombolysis, would be something like recent surgery, recent childbirth, or if they've had CPR in the last month. Now, mechanical thrombectomy is sort of the next level of reperfusion therapy, or clot retrieval. The stroke needs to be quite proximal. You need to be able to see the clot, and it needs to be within 6 or 12 to 24 hours of onset if you can see salvageable brain tissue, if you can see the penumbra of restricted blood flow to that part of the brain, but it can be salvaged. You obviously need a very specialist centre for that, and you need an interventional radiologist who is able to go in there and remove the clot. And quite often people have thrombolysis, and if you can see a very big proximal clot, they might then go on to have thrombectomy, and the response to that can be wonderful. So people can get really excellent resolution of their symptoms from both thrombolysis and from thrombectomy. So post-stroke, all patients should be managed, if at all possible, on a specialist stroke unit. Patients do much better. They should have antiplatelets. Their blood pressure and cholesterol should be controlled. You should look for atrial fibrillation, which is a common cause of stroke, and that includes paroxysmal AF, so they should have longer durations of cardiac monitoring, and you should treat it if you find it. And patients should have good stroke rehabilitation, trying to get them back as much as possible to their previous baseline of function. and they should be encouraged to give up smoking and take up healthier habits to reduce the risk of a further stroke. Now, when you have a stroke, you obviously have infarction of the brain, and that dead tissue then can swell. And particularly in young people who have a stroke, they obviously have more brain, younger brain, and particularly in an MCA infarct, which can be quite extensive in a young person, the swelling can be lethal because of raised intracranial pressure. And we call that malignant MCA syndrome, which you see particularly in young people. And the way to potentially save someone in that situation is a decompressive hemicraniectomy from a neurosurgeon. And they would consider that if there's extensive cytotoxic edema after stroke. Posterior fossa infarcts, even in older people, can also cause significant swelling because there's much less space in that area. And also, because of the swelling, it can block the flow of CSF, and you can get hydrocephalus, which might require a shunt. So if you have somebody with a posterior fossa infarct who suddenly deteriorates, you want to image them to see if there's swelling and to see if they're developing hydrocephalus and speak to a neurosurgeon. And you can get something called hemorrhagic transformation, where an established stroke can then bleed. You can bleed into that damaged area. Other causes of deterioration after a stroke: overwhelming infection from aspiration pneumonia. That is the other cause of deterioration. And I've just got a picture here of malignant MCA syndrome in a young person who did have thrombolysis, and you can see that the ventricles, the horns of the ventricles, are completely obliterated by swelling. So in terms of predictions, so it attacks a total anterior circulation stroke. The outcome is poorer if they don't have good reperfusion result, if they're a candidate for that. And that's because they have such extensive symptoms, including higher cognitive issues. A partial anterior circulation syndrome, where you have any two of the motor sensory deficit, hemianopia, or higher cognitive problems. It's variable outcome, and it depends on whether or not they have reperfusion therapies and what their baseline function was like. A posterior circulation syndrome, which is where you have brainstem dysfunction or hemianopia, it depends on how extensive the syndrome was. So the outcome is variable. And a lacunar anterior circulation stroke, one of the lacunes we talked about, those isolated distal strokes, they have a much better outcome. It's a smaller stroke, it tends to be more limited in scope. So in summary, consider stroke for any hyperacute neurological syndrome which would fit into a vascular territory. Always consider stroke. Is it hyperacute? Think stroke. What is the time of onset? Get as much information as possible. What's their previous medical history? Are they anticoagulated? Has there been trauma? Has there been recent surgery? Because you want to know, is this person a candidate for reperfusion? Can you save a good proportion of brain? Basic management, bloods, ECG, while you're organising a CT and a CT angio, you want to get them through as quickly as possible. If they're a candidate for this therapy, you want them to have it. Ensure the stroke team is contacted as soon as possible. And remember, time is brain. And outcomes depend on how extensive the stroke is, how unwell the patient is or was before their stroke, and complications, as well as their stroke rehab therapies. And just very quickly, I'm going to touch on TIA. So TIA, transient ischemic attack, it must be transient, otherwise it's not a TIA. So if symptoms are ongoing, you can't call it a TIA. It might be a stroke. So until a TIA has stopped, it is a stroke. So the technical definition is that it lasts less than 24 hours, but it's usually much less. And if you, for example, see somebody after they've had symptoms which have gone away and you scan them and you see an established infarct which would explain their symptoms, they have had a stroke, even if their symptoms have quickly resolved, because you can see an established stroke. A TIA is a temporary disruption of blood supply to a part of the brain, which then is re-established before an established stroke happens. If there is an established stroke on a scan, they have not had a TIA, they've had a stroke, even if their symptoms have resolved. So, management of TIA, they should be offered aspirin, 300 milligrams once daily, if they're not already on aspirin. They should have an ECG, you're looking for AF. A CT head if they're on anticoagulants, or if they have any other neurological features such as drowsiness, because you're looking for a bleed. Now, if they have had their symptoms within the last 24 hours, if they've had their symptoms within the last 7 days, they should see a stroke specialist within the next 24 hours. If their symptoms resolved more than a week ago and somebody's coming to you really late, then they should see somebody within a week, and they shouldn't drive until they see a specialist. So the TIA specialist, the stroke specialist, will decide whether or not this is a vascular problem, whether this was a TIA. They'll look for anything treatable, high blood pressure, AF, high cholesterol, to try and reduce the risk of a of an actual stroke going forward, the lifestyle advice such as smoking, exercise, and also they look for mimics. Could this have been a migraine? Could this have been a functional neurological problem? Is this something that can't be explained by a vascular event, by a TIA or a stroke? There's also other forms of vascular ischemia like amaurosis fugax, which is the darkening curtain coming down over the eye. That is a very distinctive TIA syndrome and often missed, and will go to eye clinics and things. You should be on the lookout for anything that is a TIA that might affect another part of the body other than the arms and legs. Brain imaging and vessel imaging can often be done in TIA clinic, and I shall leave vascular neurology there. Thank you.